Thank you so much, and thank you to the organizers for the invite. I'm also going to change my title. So we're going to do Women in Leadership, Holding Our Power to Make a Meaningful Difference, and doing it together. So, no financial disclosures. I probably would not have worn this color if I knew it was going to blend like this into the background, but that's the only disclosure. So today, for the few minutes that we have together, I thought maybe we would break it up into a personal story and a group story. So I'm going to start with the personal story. So backing up, in 2016, I was an inpatient oncologist. I love inpatient. When patients are admitted, the acuity is high, you're working in a team, and at the time, doing a lot of clinical work and also operations. Was not involved in research. But then I met David Mcdougall, and he said I could use his name. So David is a 64-year-old gentleman. He was a CEO of a tech company. He had 2 very successful adult children. He had it all. That was until about December 2015. And he started having difficulty writing checks, just writing checks at work. His hand wasn't doing what his brain was telling it to do. So he sought medical attention, had imaging, and the worst case scenario of a brain met, 1.7 centimeters in the left parietal lobe. Full staging showed that he had a lung lesion as well. Because there was motor difficulty, he had that brain met resected. And it was BRAF positive metastatic melanoma. So much optimism, right? Targeted therapy versus single agent immunotherapy versus dual immunotherapy in 2016. But David had taken a lot of risk in his life. He knew the dual agent immunotherapy was the highest response rate, and that was absolutely right for him. Cycle 1 went great. Cycle 2, 3 weeks later, also went well, until he presented to the Massachusetts General Hospital ED. That was 4 days after cycle 2. He was so short of breath. He had air hunger, and the oxygenation was about 48%, so not compatible with life. We rapidly were able to give him the oxygen that he needed. We ruled out everything else. And because of the dual checkpoint inhibitors, he was ultimately diagnosed with inflammation of the lungs, so pneumonitis related to the IPI and NEVO. And we started steroids, and he did beautifully. Discharged 6 days later. This was one of our earliest cases of this severe complication. He did well for about 3 weeks, but then he was readmitted to our hospital. Unfortunately, in that second admission, the immune system was just relentless. So the diarrhea, over 4 to 5 liters a day, was colitis related to checkpoint. His neurosystem was involved, and we were scrambling, just trying to do what we can. Unfortunately, he never made it out of the hospital. And a couple days before he went to the ICU, because I was pretty much sitting vigil with him, because it's such a helpless state, at least at that time. And he looked at me and he said, "Doc, I know this isn't good, but please tell me that you will learn from this." And I promised him that we would learn from it that day, and I promised him many days since. And so I guess one of the things I think I just want to say is maybe the glass ceiling doesn't apply if you're building your own house. So what does that mean? If something you're passionate about or some area where you want to make a difference in, how do you start? And I will say this little tagline down at the bottom, Dr. Julie Silver's Career Advancement and Leadership Skills for Women in Healthcare is held in Boston every year. Now it's virtual. It's fantastic. And that gave me the nomenclature. So she broke it down, thinking about what's a specialty clinic? Well, a specialty clinic really often revolves around clinical care, some aspect unique of clinical care. What's a center? Well, a center is much larger. So a center needs deep infrastructure. It needs staffing. It needs a footprint, so real space. In addition, it often engages both clinical care, but research, education, with a focus on how can we move things forward, being innovative, thinking about technology, thinking about quality, thinking about value. An institute is not quite as big of a center, and honestly, it doesn't have to be around a clinical care aspect. An institute could be a research institute, having some of the same similarities as a center. And then a program is much more of a catch-all term. So no matter what it is, I thought maybe as this has developed, the issue after David is I knew we wanted to focus on our institution altering our clinical care model to care for patients with immune-related adverse events. We didn't just want to care for them. We wanted to build a subspecialty expertise. We wanted to have a clinical data set so we could figure out and define these conditions. And the science had to be behind it, because how are we going to understand the mechanisms driving these events? So we wanted to do the entire gamut. And what I learned along the way is 3 things that I'm going to share with you. One is it is critical, whatever proposal you're coming up with, whatever area you want to solve, how does it align directly with the strategic priorities of your institution or department? And this is important more now than ever. And so if we go back to 2016 and we think about all the aspects we wanted to tackle for severe immunotherapy complications, both on the clinical side and the research, these are just faces of who existed at the 2016 time. But it really, you have to go to those key stakeholders in all the areas. Clinical care, who's at the institution in innovation, for new discoveries, for research, or even for medical education. So sitting down and making sure your proposal aligns. And if it doesn't align with the strategic priorities, you have to mold it to be able to hit those. And then it's all about the team. And it started just by circles and bubbles. What do we need? We need oncologists, but not just melanoma and lung who have treated immunotherapy patients for a long time. We need to sit right next to head and neck, breast, GI, and so on. And with something like immune-related adverse events, as you guys saw in previous talks, the number we are treating are increasing dramatically. Thankfully, very few die, like the patient that I explained, only about 1%. But anywhere from 10, 15% on PD-1 therapy can get severe events, up to 30% on CTLA-4, or up to 50% if we start combining agents. And so really mapping out all of the subspecialists that were necessary to be at the table, as well as who's going to do the science. So now it's 51 members across 6 different departments and 10 divisions of medicine. To the top right, you can see Dr. Chloe Villani. So she's the director of our single-cell genomics program, and there are 15 people in her lab that really bridge between the clinic and the lab trying to understand these events. And around the wheel are all the subspecialists that I talked about. Number 2, after you've aligned and developed the best team, you have to learn from similar models. So often, it's so important just not to reinvent the wheel. And so even for our case, there are multidisciplinary units for pulmonary embolism. There are international global consortium of vascular medicine, pulmonologists, hematologists, you name it. And so learning as much as we could from PERT and other organizations that were similar. So I talked about the first 2 elements. 1, aligning with priorities. 2, learning from similar models. And 3, just being crystal clear what the mission and the vision is. And so mission, for example, for the severe immunotherapy complication, it's easy. We want to take the very best care of patients on immunotherapy that have adverse events. We want to engage in research that's going to move that, advance that field forward, and we just want to train the next generation while we're doing it. And the vision, I could share that later as well if that's important, but when you're visioning something, you really say 5 years from now, September 24th, 2027, these are the new team members. This is what it looks like from what we've accomplished. These are the grants that we have. These are the diagnostics, and so on. So just so clearly visioning it. And I will say there are 3 quick reads. And again, they can be very quick. But if you're thinking about a mission or a vision, I think this top left book, The Joy of Strategy, it's written by a coach, Allison Rim. It's fantastic. I actually go through it every year just to hone that mission, vision, and programming. The second, you have to know yourself. And so what do I mean by that? This Strengths Finder, there are other ways to find strengths as well. But even if you just buy it for the 20-minute quiz, it's worth it because you can figure out what you have. But more importantly, you can figure out what you don't have, and you can make sure your team members embody those qualities. And then the third, there's not enough time, and other lies we tell ourselves. Again, a quick read, but I know that sometimes it's hard to think about leadership or starting something new because you care about work-life balance. You care about your family. I do too. I'd like to stay married. I'd like to take care of Oliver, who's 7, and Sophia, who's 3.5. But I do think there is time for things that are important. And then when you're going to the institution and thinking about leading an effort, how do you get creative with ROI, the return on investment? Now more than ever in academic medicine, I think you have to be so clear what the ROI is before anyone is going to help along the way. So it's not just revenue and expenses. It's not just that. Clinical care, as more trials are becoming more complex, we need, say, a toxicity service to think about caring for those patients. Innovation, what diagnostics could come out of this? New discoveries, what treatment targets could come out of this? Research-wise, it's important for people at the institution academically to dock to a research group that they can write a K about, that they can write R01s on. The network, our institution, is central, but we have a lot of satellites, and we need to make sure they have the same access and get help when they need to. Medical education, grant opportunities, reputation, if an area or a hospital is interested in a certain area, and could that be a growth area for patients? So I would just say at the end of that personal story, I feel like great leaders don't set out to be a leader, they set out to make a difference. And once you know that difference, it doesn't really feel like leading. It just feels like trying to do something that feels important to you. And it's never about the role, it's always about the goal. And then the second shift part of how do we do this together. So I'm not going to go over the data that we know exist in terms of gender disparities. Whether you want to look at compensation, grant funding, development funds, recognition, speaking opportunities. I like this, though. We have it on the whole docket. Leadership as well at your own institution, at medical journals, at societies, and so on. But I want to tell you what we're doing about it. So about 5 years ago, in 2017, it became really clear that already our institution was increasing the number of oncology faculty, and we were starting to get more fragmented into our network. In addition, science and clinical care just seemed like they were getting further and further apart. And so we wanted to develop a sense of community where women across the cancer center, both clinical and research, and in our satellite network could find just a shared sense of belonging, of purpose, of values, and most importantly, truly support and sponsor each other through our careers. So who are we, or who do we serve? Well, it started out with medical oncology, but then we thought it's really important to think about the 30 female surgeons that exist, the 18 radiation oncologists, fellows, and integrating fellows and faculty together as we're going to share the same challenges. The Cancer Center Network, as I talked about, pediatrics, the research area, as well as the subspecialists who wrap around our patient population. So if we go back, it started as, let's get together as a group. About 5 times a year. It was more lecture series based than anything in 2017, 18, into 19. But the Mass General Physicians Organization invested with some grant opportunities, and that's what really changed this organization. So in 2020, not just were the social and networking events held, but a true engagement with an outside coaching vendor led to a 4-part leadership series. These were 90 minutes each. People were engaged. They had to do all 4, as well as engaging those network clinicians and even thinking about a little Peloton. You know, that was the pandemic. And so we ride every Wednesday, every Friday at 6 a.m. And continue to do so. We do 5Ks together, so we do runs, bikes, you name it. But then in 2021, we took that a step further. And again, more of those puzzle pieces started to add on. And I will say that out of this, once you have that community and connection, people wanted vulnerability sessions, meaning journey through grief with grace, 2 people who lost their husband unexpectedly. And also, what do colleagues do when someone's had that kind of loss? Or infertility, which has now become a series. And then in 2022, most recently, focusing on the young moms, so maternity program, as well as our newer faculty. I didn't realize how hard it is to onboard in a post-COVID world because people are not around as much as they used to be. And so this is a very vulnerable group if we want attention. So about 40 are in attendance at any one session. You can see it's mostly med-onc, but we're starting to get other colors of bars, and it's been over 13 engagements in just a couple years. And a few things those grants did do is allowed me to think about how do we measure progress in this area? How do you measure a group like that? And so we thought about programming metrics. And as part of that 4-session leadership series, everybody had a pre-specified goal to start, and 100% achieved progress in that goal. 42% achieved high-level progress. 88% shed perfectionism, which is probably going to be important as we try to get to the top. 67% improved strategic thinking. 55% improved with self-promotion. 61% with results-oriented thinking, and over 80% with a commitment to career growth. So post-pandemic, trying to just get back on in terms of a focus. And I think it's hard to move the needle on organizational change. That's why I'm really surprised by the number at the left. But 55% say they increased their commitment to the organization because of the program. So meaningful difference. So we learned, though, that was a big group coaching. And honestly, we went with more of peer group most recently in the most recent year. And after that, and as we think about WIO in general, we thought, how can we ask the tough questions? Is a group that is funded, does it actually make a difference? So how does the Women in Oncology program affect how valued you feel? And I think that's a layered question. It's not just all about one group or a few events, but 73% did say a great deal or a lot. Or to the right, it's affecting over 50% people with burnout. To the bottom left, I'm concerned for multiple reasons, but I think it's the most important box in the deck. How has the Women in Oncology program affected your likelihood to reduce your clinical time or leave the organization in the next 2 years? And 41% said a great deal or a lot. And over to the bottom right, how has the Women in Oncology program impacted your quality of life? That's over 60%. So what are those benefits? Well, I think it's clear on an individual basis, but it's also important in patient care. So it's fostering clinical connections, whether that's that big screen, now we're meeting more in person, thankfully, or the smaller peer sessions, but it's important for our network clinicians. We want to integrate, and they really say by networking in the WIO, I've been able to make personal connections with those female faculty members for clinical trials, for consults. I think this is improving the quality of care that I deliver. And it's also meeting on this individual level. I think we all know community is a huge sense of being resilient in these times. And so building a sense of community and feeling valued. Second person says it's a big portion of retaining me. Third, authentic and meaningful relationships. And the fourth led me to this new faculty vulnerable situation because she joined the MGH in the fall, and it was one of the first groups that she became a part of. It was invaluable to have that connection and community. She also appreciated something we do in the winter called the Winter Warrior Challenge. You can see the picture from the right. You have to dress warm around here in Boston, but we get outside, walk a mile a day. Every day we keep each other accountable. And so it's really just that connection to get through. And we do have a website, namely because if anyone, this is a QR code to that website as well, but if anyone is thinking about an organization like this, I thought it might help just to have a central docking unit, and it lists all the events we've ever had since 2017, because I thought if nothing else, maybe it can generate some content for others. There's also a piece on there that has impact, so if you're trying to make a proposal about this or an initiative similar and thinking about what the impact it might have on faculty. So I just want to thank David for his inspiration so long ago. At the time of autopsy, he actually had not one single melanoma cell. Since then, though, we've made great progress. I think he would be proud. In addition, I want to thank all the women in oncology and all of you that are in this room. So happy to take some questions as well. Suzanne.
How much money do you get?
Okay, I love it. How much money does it take, right? So let's go back to when it was just 5 social networking events a year, okay? So the first year, $5,000, about $1,000 an event. The second year, I thought, that was pretty good. I think we can do better. $8,000 from the Cancer Center, okay? Then when we got the grant, you either go big or you go home, right? So it was $25,000 for the first grant with indirects. At our institution, that's 20% more. I think it takes $25,000 a year to do true leadership program development and to have the community aspect and to have program management. I didn't get to go into this, but by year 3, I realized we need administrative to plan the events, for the expenses. A lot of those details needed program management. So I budgeted in $2,500 for her for the year, and so I really do think it's $25,000. because there was a chance I just went for 35 the next year. We did get it from the MGPO for renewal, but that money has run dry. So now I think the happy number, if you think about an organization, that is we invite over 200 people. People engage in when they can or in what they feel is meaningful. But I think that that's about the right number. I'd be interested what your thoughts were.
Oh, we have nothing, so
yeah.
I mean, anything would be great.
Yeah.
So.
Start with 5,000. No, I'm just kidding.
And
anything else?
These are internal grants?
They were internal grants.
Do you know of any national
So ASCO had a wellness thing for, I don't know it as much, but somebody had mentioned that as an opportunity. I also met with a couple different foundations, but nothing really took. That website also has like a support our effort. And so one of the aspects that I thought is if we think about grateful patients and would they be able to support or think about sustaining a group like that. And then the last part was we were getting professional development fees. They were about $5,000 a year. And I thought maybe women would be able to kind of put some of that professional development fee to an organization like this, especially if they were highly engaged. And then they cut it. So that didn't work. But if you have something like that, that might be an opportunity.
I'm curious about what you think about that data point. More than 50% would consider cutting back on clinical.
41. It's 41. It was not 50.
Can you just repeat the question?
It's 41.
Institution's goal is to retain
I will.
their female, brain hive, so to speak. Doesn't that sort of work against that?
So does it work against that? Sorry, say one more.
I mean, if the goal of these grants and all of this
Yeah.
wellness is to retain the female physician force, and you're actually encouraging them to, not encouraging, but maybe empowering them to consider leaving.
So I think it's how I phrase the question, especially when you're in like short slides like this. What we ask is, were you going to leave independently? Did this group make a difference? 41% said it made a great deal or a good difference in the staying or retention.
Oh, okay.
Yeah, yeah, exactly. That would be really bad. We're going to leave and we're leaving in mass. Yeah, that would be bad.
I just want to know, is it only oncology physicians?
It's such a good question. So for some of the programming, it is only oncology physicians, meaning for that leadership development, just because there are nuances to that curriculum, that was for MDs. But a lot of our opportunities, so even the Peloton, for example, or certain of the strategic, the social, the networking, those are open to women in oncology across all nurse practitioners, nurses, even administration. For example, last week we had an MGH Everyday Amazing Race, and probably only 10% of our team was actually physicians. So there are certain things that are physician only because there are unique circumstances to that group, but there are some things where we open it up. Good question.
It's a great talk. I see the women in oncology on Twitter all the time. Question, so I'm from a smaller institution, and I love the idea of this, but it would be hard to do with just oncology, just the nature of the size. Is this something that you could see being in a women in medicine for a community setting, smaller place?
Absolutely. And in fact, that was kind of how you see, we started with MedOnc. We tacked on, RadOnc, SurgOnc. But also you can see we did palliative care, we did PsychOnc, we did subspecialists as well. Absolutely, it could be medicine, especially when you have shared challenges. So I think that's where you would go. The biggest thing is you want to invite about, I would say, 10 to 20 times the number of what you want at the event. And then take every RSVP list and cut it in half if you're ordering food. So people really want to be there. They think they're there. That's what's also interesting, is that I think some of the benefit and some of the replies are really more about I think I'm involved, but I might not be going. So just cut it in half. Thank you, guys. I really appreciate it.